Hi, good evening. Is the audio video fine? Okay, is it okay? The chat box, live chat is in front of me, so just let me know if you can see the things. Okay, because there is some. Yes, I can see it's going nice. Okay, so welcome to this mini test series just before the exams. Okay, so this is there are 15 questions of general surgery. Yesterday it was GIT and the other part was taken by Dr. Tiwari sir. Okay, so let's see 15 questions. We need to see that in 1 hour. Okay, so I guess you have seen the paper already, and now we'll discuss the questions. MTS was tough. This Umesh, you are saying this MTS was tough. Okay, let's see how tough it was, or how maybe some silly mistakes you have done. So let's see. Okay, see, questions are basically for the discussion. Don't think that in the exam you'll get the exact kind of questions, but yes, exact topics and exact maybe scenarios and the kind of way they ask question, that will be similar. Okay, so not exactly same. Okay, let's see. 32-year-old female, high speed motor vehicle crash, and heart rate is 95, BP is fine, hemoglobin is also fine. On fast, a moderate amount of fluid, and grade 4 liver laceration is seen on CT scan. Vital after 6 hours is okay, slightly high heartbeat, BP is still fine. What is the next most appropriate step? So this question is about abdominal trauma, blunt abdominal trauma. So in abdominal trauma, see, if the patient is, let's see the first question, hemodynamically stable. This is our patient. Suppose patient is unstable. If the patient is unstable, what will we do? You all know, fast, and then you can go for surgery. But if the patient is stable, the next investigation you will do is fast, which is done in this case also. Fast. That was showing some free fluid. But because the patient was stable, so you go for the investigation of choice, that is CCT. Okay, CCT. So based on this CCT, there is this grading, AAST, American Association of Surgeons for Trauma grading. Question is about liver trauma. So in liver there is 1 to 5. There was 1 6 also, but now in the new Bayesian law they have put just 1 to 5 grading. Now see, if the patient of liver trauma is stable, we all know that liver has the property of regeneration. So if the patient is stable, we'll go for non-operative management. Non-operative management will, the answer for this question is no need of surgery, no need of angiography, no need of repeat fast. Just keep the patient admitted in ICU in under monitoring, and when you do the monitoring, you check the vitals, you check the hemoglobin. So this is repeated hemoglobin determination. This is the answer. So now tell me if any of you have got this one wrong. Okay, just tell me. I know that maybe 1 or 2 question I'll explain, but I guess this is clear cut. There should not be. The role of angiography. Let me tell you what is the role of angiography. Suppose there is this CT scan you will do. On this CT scan, suppose there is an injury and that is having contrast extravasation. Now what is the meaning of contrast extravasation? That this area is still bleeding, but the amount of bleeding is not significant enough to cause the patient becoming unstable. Patient is stable only, but that area is still bleeding little bit. So contrast is that dye which you have given through the vascular system, that is leaking from one area, means that area the vessel is not intact. So in this case you go for angiography. Suppose in this the question was CT shows, here it is written very clearly, no active extravasation. Can you see? No active extravasation. Suppose they write there is extravasation, then angiography would have been the answer. Okay. Now let's see next. Suppose the patient is unstable. Okay, suppose like why not laparotomy? Because the patient is stable, Anila. The patient is stable. Suppose patient is unstable, then you don't have an option, you have to operate. Suppose like somebody asked just now that suppose initially patient was stable, but on repeated when you do the monitoring, patient becomes unstable. Then also you have to operate. Okay, so initially stable, the moment patient becomes unstable, unstable means there is severe bleeding, and the bleeding is so much so that the BP has come down, so means at least 30% of the blood patient has lost. So in these scenarios you have to operate. Okay, so when the patient is unstable, when you have to do surgery, now what surgery we do? When we intervene in these cases, that is what I am telling you, if the patient is unstable. Liver trauma, if the patient is stable, please do not open up the patient. If there is contrast extravasation, do angiography. No contrast extravasation, keep the patient under observation in ICU, check the vitals, check the hemoglobin. This is all you are supposed to do. So in surgery, what we do is, the first thing is exploratory laparotomy. You open up the patient. After opening up the patient, the first thing is 4-quadrant abdominal packing. Okay, see, these are the abdominal packs. So suppose this is the patient. When you open up the patient, all these packs, lots of these packs, you put in all the 4 quadrants. Then remove pack one by one. Remove packs one by one. Okay, during this whole period, the anesthesia people are taking care of the patient. They are giving fluid, they are giving blood to the patient. Yes, there is fluid in fast, but that does not mean that you have to operate. Operate ke liye patient should be unstable. Remove packs one by one. Fast, so we have done because fast is the next line of investigation. But what is the investigation of choice in a stable patient? CCT. If you have to open just by looking the free fluid in the fast, then there is, what is the role of CCT? Okay, so fast you have done because that is the next line investigation. Now once you remove the packs one by one, you will see that the patient is having liver injury. I told you in the classes multiple times. What will you do? Push, plug, Pringle. Now push is just give pressure. Plug, Pringle is putting this clamp on the clamp, or surgeon puts the thumb and the index finger, and they clamp the hepatoduodenal ligament. And if despite that the bleeding is there, then pack the liver, pack the perihepatic packing. Okay, so push, plug, Pringle, perihepatic packing. These are 4 P's in the liver trauma. How much fluid on the fast should be to do the surgery? There is no such criteria on NEET PG. Fast is just to how much fluid is there so that fast can detect it. That is 100 ml. But suppose fast will not quantify the amount of fluid. Okay, fast is we are doing very quickly. Fast will just tell that whether fluid is present or not present. If it is present, it is positive. If it is absent, it is negative. Now fast positive. Okay, let's see this scenario. You have done the first investigation as fast. Fast is positive. Patient is unstable. You operate. Fast is positive. Patient is stable. You get the CT done. And depending on the CT and depending on the organ injured, now you will take the decision whether to operate or not to operate. In this question, because the organ was liver and the patient was stable despite any grade, we decided not to operate. Grade 4 laceration होने पर भी नहीं करना अनुष्का. Yes. Suppose the question is about spleen. Suppose the question was about spleen and after CT it is grade 5 splenic injury. Then you do splenectomy. Okay, so spleen, the guidelines are different. Liver, it is different. Kidney, it is different. In liver and in spleen and kidney, grade 5 you operate only. Grade 4, sometimes you operate, sometimes not. Most of the time in spleen you operate, most of the time in kidney you don't operate. But in liver, does not matter what is the grading. If it is stable, you don't operate. You don't operate. Okay, so this is the answer. Repeat, no repeat fast, no angiography, no surgery. Yes, okay, correct, Anushka. Everybody fine? See, a patient of abdominal aortic aneurysm underwent the following treatment. On follow-up CT, there was increase in size of aneurysm. What is type 3 endo leak? Abdominal aortic aneurysm underwent this treatment. Now you tell me, this image is, what is this treatment option? Yes, if the angio shows active bleeding, patient is stable, you do angioembolization. If there is, see, first of all, you are doing CT only if the patient is stable. So obviously, if they have given CT, means the patient is stable. Otherwise, unstable patient may, you send the patient to CT, you are sending the patient to directly to God maybe because there is active bleeding. Okay, so CT means patient is stable. Angiography shows extravasation, do angioembolization. No extravasation, conservative, non-operative. Okay, what is this treatment? Yes, Harshita, very good. This is endovascular aneurysm repair. Endovascular aneurysm repair. Now you see, when there is abdominal aortic aneurysm, this is very important question. Indication for surgery. Okay, either the patient is having symptoms, or in asymptomatic patient, diameter more than 5.5 centimeter, or the rate of growth is more than 1 centimeter in 12 months, or more than 0.5 centimeter in 6 months. Okay, this, so you all know, this is very important. Everybody should know if you don't know by now. Okay, remember one point I am telling you. This diameter more than 5.5 centimeter is for males. Suppose in the question they ask in females what is the cutoff size, it will be 5 centimeter, because the chance of rupture is more in females as compared to males. Although the aneurysm incidence is more in males, but the risk of rupture is more in females. Okay, so this I'm sure you know. So when you do the surgery, there is one open surgery. Okay, open surgery may, what we do, see, you expose the aneurysm, and then there is some thrombus inside. Most of the time there will be thrombus. You remove the thrombus. Those small vessels which are opening, you ligate those vessels and put a Dacron graft and close it and come out. So now the blood will go through the Dacron graft and it will not rupture, it will not bleed. Okay, so fine. This is the open Dacron graft replacement. But these days the preferred treatment is the endovascular. Endovascular is like this. You come from one side and you put a major piece. Suppose this is one piece. This is one big piece, single piece. So this is just see this. This is one piece you have introduced from one side. From the other side, you will come and you will put another small piece. Okay, it will go and fix it here. So now this treatment is done. Now the blood will go to both the sides. So basically, just remember this endovascular aneurysm repair. It is a two-piece, we call it as stent graft. Two-piece stent graft. One major and one the smaller piece. So this is EVAR. So now when we do a EVAR type of surgery, so just see, the blood should ideally go from this. Suppose even after this diameter of the aneurysm increases. So why it is increasing? Okay, there should be some leak, there should be some blood still coming in this area. That's why it is increasing. So this increase in the diameter after doing endovascular aneurysm repair is known as endoleak. This is known as endoleak. Okay, so that is clear. Now we know what is endoleak. There are different types of endoleaks. See the types. In type 1, suppose the leak is from the proximal end of the stent graft, it is 1A, or it is from the distal end, it is 1B. So that is 1A and 1B. Type 2 is, see those small vessels which are opening in the sac, mostly there is no bleeding from there. Suppose there is backflow of blood from these vessels. That is 2. Okay, retrograde flow from the small collateral vessel, that is 2. Now 3, just see 3. In 3, 3A is, see, I told you that there is this component. So if there is leak from this area and the diameter of the sac increases, this is 3A. So the main body and the smaller body, they got separated and the blood is coming from this and filling in the sac. 3B is, suppose there is some defect in the main stent graft, there is some hole there. 4 is when there is porous wall, the whole wall is porous and some blood is seeping out and causing increase in the diameter. And 5 is despite no leak, no hole, no seepage, somehow the diameter of the stent graft is increasing, and that is known as endotension. The reason for that is not known, it is known as endotension, increase in the diameter without any visible endo leak. So there are 5 types. Remember, type 2 is the most common type. Okay, so 1 and 3 you need to do immediate repair. 5 you need to do replacement, although not immediate, but that graft needs to be replaced. And remaining 2 and 4, usually the bleeding stops spontaneously. You don't have to do anything actively as such, just wait and watch and this will heal. Okay, so these are types of endo leaks, and this question was about types of endo leak. Type 3B is, see, suppose this is, okay, Aisha, like suppose someone is wearing a shirt and that shirt has a hole that is torn from some area. So that, and from there suppose something is coming out, that is a hole. But suppose someone is wearing a kind of, what do you say these days, you have this linen type of shirt which has bigger holes, and actually there is no hole as such. The fabric of the shirt is such that any amount of sweat immediately comes out. So type 4 is that linen type of something that the whole wall is porous and the things are coming out. And type 3 is that one tear in the shirt, through that that is a proper hole. So that is the meaning of difference between 3B and 4. Okay, the whole thing is porous and there is just one. No, there is no name for this kind of endotension classification. Okay, so now we'll see the answer. What is type 3? Type failure to seal between components of a modular. This is 3A. Looks our answer. Continued filling. This is type 2. Seepage through a porous. This is type 4. Failure to seal the proximal seal zone 1A. So the answer here is A. Answer here is A. I'm sure this is okay. You're going very slow. Okay, let's see. Okay, next question. 24-year-old male and with gunshot wound to his right arm, decreased right radial pulse and a non-expanding hematoma in the forearm. No hard signs of arterial injury. Undergoes CT angiography. Contrast extravasation from the radial artery. On examination, he has no sensory or motor deficit in the palmar arc. Which of the following is true? The ulnar artery is the dominant circulation to the hand in 80 to 90% of the people. Not 40%, 80 to 90%. Yes, you need to remember this classification. There are questions on this, Asmita. Radial artery may be safely ligated. See, this hand is dependent on 2 arteries, radial and ulnar. Now, in 80 to 90% of the cases, the majority of the supply of this hand is via ulnar artery. So, if both the arteries are intact and one of them is gone, like suppose radial is gone in this question, you can very safely ligate radial artery. Radial artery may be safely ligated in this patient because the ulnar is intact. Arterial reconstruction is not mandatory, and interposition graft, the things are not required. So in these cases, radial artery can be safely ligated. Like suppose there is injury to the external carotid or internal carotid. Internal carotid you need to repair. External carotid you ligate because the other side external carotid will take care of the organ which is supplied by that. Similarly, if you go in the pelvis, external iliac artery you need to repair. Internal iliac artery on one side you can safely ligate because the other side internal iliac will take care of the pelvic organs. Yes, so I guess this question most of you have done correct. Interposition graft, because this is not the end artery. Okay, this you can do. Suppose there was injury to, suppose the question says injury to brachial artery, okay, or injury to axillary artery. If it is an end artery, because of that, if you ligate, there can be permanent damage. In those cases, you can do that. Okay, this vein graft if there is this end artery, internal carotid, now femoral artery, external carotid, external iliac artery. So if it is end kind of artery, that ligation can lead to permanent damage, then you can do that. Otherwise, there is no need. Okay, because there is contrast extravasation from the radial artery. Okay, there is contrast extravasation, means there is a leak. So the question, they are not asking what you will do. The question is, which of the statement is true? Radial artery may be safely ligated in this patient. If at all there is need to do some surgery, you can safely ligate, or you can wait and watch also. Okay, either you wait and watch, or you can safely ligate that. See, they have not asked that what you should do in this case. They have asked which of the following is true. Which of the following is true? If suppose I was the treating surgeon there, I would have wait and watch in this case, and I would repeat the CT or in the angiography the next day or the next day. Okay, there is no need to operate as such. The question is not about what you will do. The question is what is true. Arterial reconstruction is not mandatory. I mean, I explained everything why it is not mandatory in this case, because the hand is supplied mainly by the ulnar artery, and if that is fine, you don't have to operate. And you can check in those cases where you want to check whether radial and ulnar both are working or not working. What is the name of this test? Tell me the name of this test which checks the patency of both radial and ulnar artery. Anybody? What is the name of this test for patency? I am sure you remember. Allen's test. Okay, mostly people do this before taking ABG and all. Yes. Okay, what is the least appropriate therapy for a patient affected by Phlegmasia cerulea dolens? Cerulea dolens. What is the meaning? Blue leg. Blue leg. Yes, Allen's, all of you are correct. Blue leg. Okay, so this Phlegmasia cerulea dolens occurs when there is extensive DVT of the common femoral vein, iliac vein, and any other small collaterals which are going around. So every possible vein which can bring the blood from the limb to the rest of the body is kind of thrombosed. Very extensive type of DVT. So in these cases, there is risk of venous gangrene. Okay, if you don't do anything, there is risk of venous gangrene. So the question is, what is the least appropriate therapy? I am sure all of you have done correctly this. Observation. Okay, this you should not do. Your patient will lose the limb. Targeted thrombolysis can be done. Thrombectomy, surgical thrombectomy can be done. Systemic coagulation can be done. But observation is something you should not do. This is a kind of surgical emergency. Okay, usually see this is how in normal DVT appears, which is in the calf. There is redness, there is erythema, tenderness, pain. This is Phlegmasia alba dolens. That is mainly because of DVT of the femoral vein leading to edema, and the whole leg edema can lead to this pale appearance. And this blue leg is Phlegmasia cerulea dolens, and cerulea is obviously more dangerous. Both alba and cerulea are dangerous. Okay, meet this is like 1 hour session, 15 questions, and if I go for CAP, I'm sure you know CAP. Meet I'm very confident about this thing. I know you we have like chatted in other sessions also. I know you know it. If you have any question, anything, you can ask me later. Okay, so this observation, no, even in alba dolens, initially you can give this systemic. You have to do some kind of anticoagulation, maybe not surgery per se, but anticoagulation you need to do in that case also. Observation is something which you should not do in any DVT for that matter. Even in usual calf wala DVT, we give low molecular weight heparin. Okay, so in no case you can do observation. You have to start the treatment. In alba dolens also, you start the low molecular weight heparin, then you wait and see the response. If you see that response is not good, in this case also you can go for catheter directed thrombolysis. Okay. Both the observation though as such is absolute no in DVT. 57-year-old female, 1.5 centimeter infiltrating rectal cancer, clinically negative axilla, and ER negative, PR negative, HER2 positive. So HER2 enriched type of molecular classification. She comes to your office to discuss the treatment option. What would you recommend? Okay, so what is this? A T1 N0 M0 looks like this only, although it is not mentioned about the distant metastasis, but it looks like this. And patient is ER PR negative, HER2 positive. So see, if I go and see, we discuss the treatment of breast cancer, it is whole, I mean more than 1 hour it will take in that. Let's see the options wise. Modified radical mastectomy can be an option, but alone, no, this is, I mean most of the people these days will go for breast conservation in these cases. Wide local excision is breast conservation surgery, radiation, and tamoxifen. This is okay, this is okay, this is okay. But tamoxifen you give for ER/PR positive, our patient is negative, no use. Wide local excision, fine. Because the lymph node is not involved, sentinel lymph node biopsy, very good. Radiation is must for all the patient of breast conservation therapy. And chemotherapy with trastuzumab. Trastuzumab is, yes, important in this case. Trastuzumab is important because patient is HER2 positive. Modified radical mastectomy, adjuvant chemotherapy can also be done, but the best answer here is C, like all of you are saying, C. C is correct. Okay, in this there is no confusion. This patient is a very well and very nice candidate for breast conservation therapy. Okay, so should I go to the next? Okay, let's see. This maybe you have done wrong in this case. This is what I am thinking. Lymph node status is assessed clinically, as well as when you go for the ultrasound or mammography, they will check the axilla also. Ultrasound and mammography check the axilla also. Clinically, as well as in that case, internal memory lymph nodes you will know by the CT scan. It has no, the worst prognosis is TNBC, Anila. TNBC, triple negative breast cancer, is having more bad prognosis as compared to ER/PR negative and HER2 positive. Triple negative has the worst prognosis. 25-year-old man undergoes a chest X-ray to evaluate a shoulder injury that is sustained during some incidental mediastinal mass was seen. Anterior mediastinal mass. Tumor markers show an elevated beta SCG and AFP. What is the most likely diagnosis? What is the most likely diagnosis? Why not D? D can be an option in this case, but looking at very nice clinical parameter, that 1.5 centimeter clinically negative axilla, you can very well go for C. D can be an option. Definitely you can discuss the patient. If the patient says no, I want MRM only, then you can go for MRM in that case. Okay, so D is definitely a viable option, but as the exam says you have to mark the best answer, C looks very much best answer. Okay, so maybe this is one topic which you think that maybe not discussed usually in the classes and all. Let me tell you, see the area behind the sternum, just listen to this. Area behind the sternum is mediastinum. That area is mediastinum. Let's see, this is the sternal angle. This is the sternal angle, whatever you call angle of Lewis, sternal angle. The area behind the sternal angle is superior mediastinum. Superior mediastinum. And below that everything is inferior mediastinum. Inferior mediastinal. Even if the question was more than 2 centimeter, then also Aisha, option number C would have been the best answer. Okay, superior mediastinum, below that inferior mediastinum. Inferior mediastinum can be further divided into anterior, middle and posterior. Okay, so anterior, middle and posterior, these are inferior mediastinum. The area which is anterior to the heart is anterior mediastinum, posterior to the heart is posterior mediastinum. Now let's see what are the differential diagnoses, what can be the different tumors in this case. Superior mediastinum, I'll tell you the differential and I'll also tell you what is the most common in that particular mediastinum and what is the most common in overall mediastinum. Superior mediastinum, thyroid, retrosternal goiter. This is the most common. Then there can be lymphoma and there can be parathyroid. These three are the common differential in superior mediastinum. Anterior mediastinum, most common, thymoma, most common from the thymus gland, lymphoma, and germ cell tumor. Germ cell tumor, which is there in the testis. Remember, seminoma, non-seminomatous germ cell tumor. This is thus after testis, the most common site of germ cell tumor is this mediastinum, middle mediastinum, cystic lesions, lymphoma, and mesenchymal tumors like lipoma and all. Here the most common is this cystic lesion. Posterior mediastinum, neurogenic tumor, cystic lesions, and mesenchymal lesions. These mesenchymal can be seen here also. Most common is neurogenic. Okay, so I'll just tell superior mediastinum, most common thyroid. Anterior mediastinum, thymoma. Posterior mediastinum, neurogenic. Middle mediastinum, cystic. Overall most common mediastinal tumor is thymoma. So what was given in the question? Question was there was some mediastinal mass, and what was given more? Anterior mediastinal mass. What else? Beta HCG, alpha fetoprotein. So it cannot be thymoma. It is non-seminomatous germ cell tumor. Non-seminomatous germ cell tumor, we all know that alpha fetoprotein is never raised in a pure seminoma. It is raised in non-seminomatous germ cell tumor. So that's why the answer is C. Yes. Neurogenic tumor, Revati, can be neuroblastoma, schwannoma, neurofibroma, even pheochromocytoma can also be seen. Revati, you are correct. No, most common is thyroid, retrosternal goiter, mediastinal goiter. That is more common in this. Lymphoma is also very common, but thyroid overall is more common. Okay, so that's why answer is C. I know most of you marked thymoma, but just think why beta HCG and alpha fetoprotein will raised in a thymoma. Okay, next question. 42-year-old female associated with hyperthyroidism, diffuse thyroid swelling, pretibial myxedema, like it is shown in the figure, and suppressed TSH, elevated T3. So what is your overall diagnosis? Pretibial myxedema, diffuse thyroid swelling, hyperthyroidism, very classical Graves. So this is a Graves disease, which is an autoimmune disease. Teratoma is a part of Ashura. That is a type of non-seminomatous germ cell tumor only. Okay, it is a type of it comes under non-seminomatous germ cell tumor. Okay, so when we say that alpha fetoprotein is raised, beta HCG is raised, beta HCG, remember, is raised in which type of non-seminomatous germ cell tumor? Now let me ask you why it is not teratoma. Beta HCG is not raised in teratoma. Beta HCG is raised in which type? Which type of non-seminomatous germ cell tumor? Okay, in gynae also you read about that tumor. Choriocarcinoma. Okay, so that's why that choriocarcinoma, teratoma, yolk sac tumor, embryonal cell tumor, everything comes in non-seminomatous. That's why that is a better answer. Yes. Okay, so this patient is Graves' disease. What is the next best step? Thyroid answer. Okay, I am sure this most of you have marked correct. This is radioactive iodine uptake test. Radioactive iodine uptake. Thyroid peroxidase is seen in Hashimoto's. PTU you can give to the patient of Graves if the patient is pregnant, and especially in the first trimester of the pregnancy. This patient is first of all not pregnant, so obviously there is no question of trimester. FNAC is not indicated in Graves. This already has been asked in NEET exam. FNAC is not indicated in Graves. Okay, so that's why the answer is A. If Umesh, you were asking why not option C, I guess I have just explained why not C. Okay, PTU is only for the, because PTU although is a antithyroid drug, but it has a serious side effect like liver toxicity, so it has to be used only if it is absolutely required, like in first trimester of the pregnancy, because at that time carbimazole or methimazole sometimes rarely can lead to aplasia cutis type of congenital disorder. So for that organogenesis period, first trimester, we will avoid that and give PTU. Okay, so this answer is correct. No question in this. See, this is how normal on radioactive iodine uptake, normal thyroid, it is approximately 15%. Graves' disease, the uptake is more than 90%. So RAIU, this is the normal uptake, this is the increased uptake, and just remember one thing, decreased uptake is seen in thyroiditis. Thyroiditis, the uptake is less. If carbimazole was there in the option, see, first of all, what is there, then what would have been the answer? Questions are not make like that what would be the answer. But still, chalo, for your question, I'll say even if there was carbimazole, then also option number A is correct, because they have asked what is the next best step. So first you need to make the diagnosis, and for diagnosis, radioactive iodine uptake is done most of the times. Okay, management का meaning होता है investigation as well as treatment. Okay, so in the management, next best step would still be RAIU. Okay, so this is the answer there, very clear cut A. Let's see this. So very repeatedly asked question. I'm sure video. I don't know video will be there or not, but I guess it will be there on the NEETPG app, and also they will upload my, I guess, this PDF there. 26-year-old man, injury and the lateral side, left sided blunt trauma, primary survey is fine, some fracture, chest radiograph shows elevated cost, air fluid levels in the chest. Air fluid levels in the chest, you can see very nicely here. So before I say anything, just tell me what is the diagnosis. Before undergoing the chest CT, a NG tube was placed, and during confirmatory radiographs, diagnosis of the injury is made. Which is true regarding this patient's injury? Okay, tell me what is this injury. Very clear cut, very obvious, very commonly asked question. This is diaphragm injury. Okay, traumatic diaphragmatic rupture. Okay, traumatic diaphragmatic rupture. So let's see the options first. It requires full excision of the diaphragm with prosthetic repair. Why would we excise the diaphragm? Okay, it is not a tumor. This is the most wrong statement, I guess. It can be readily identified on radiographs and CT. It may be identified, but this I teach in my classes also, that diaphragmatic injury is very frequently getting missed on the initial survey and initial evaluation. So it is not readily diagnosed. It may be diagnosed, but many times it gets missed initially. It heals spontaneously. It never heals spontaneously. You have to do surgery in diaphragmatic repair, no matter it is small or big. It will not heal on its own. It is best identified and repaired via laparotomy or laparoscopy is the obvious correct answer. No, we don't have to do open this is laparotomy or laparoscopy. These days we have recently treated 2 patients of traumatic diaphragm, although they presented after 2 months, but laparoscopically it was because a small rupture, so we brought the content back, and in that area we put a mesh and the patient is absolutely fine. So it can be done both by open as well as laparoscopic, and for that matter it can be treated by thoracoscopic approach also. People, they have done VATS for treatment of diaphragm injury. Okay, so this is D, answer D. 55-year-old female, surgical evaluation, PTH is high, 280. Normal PTH I will write. Normal is 15 to 65. See, if it is written nanogram per liter, if it is written picogram per ml, is the same thing. So obviously it is high, 280. Serum calcium is 14.5. Normal is 9 to 11. She has a past medical history of renal failure and jaw tumor syndrome. Most likely diagnosis in this patient is. See, one important thing you need to remember that it is obviously hyperparathyroidism. Hyperparathyroidism. Now, when we talk about hyperparathyroidism, there can be primary, secondary, or tertiary. I'm sure you know the difference. Primary is because of the parathyroid problem itself, like adenoma, hyperplasia, or carcinoma. Secondary is mainly because of, okay, I'll write parathyroid, adenoma, hyperplasia, or carcinoma. Adenoma being more common, hyperplasia is less, and carcinoma is very rare. Secondary is because of chronic hypocalcemia, like in CRF. And tertiary occurs when the gland becomes autonomous because of prolonged secondary, that even after suppose renal transplant there is still increased PTH. So two things, carcinoma, which is very uncommon, two cases in which you should be suspicious of carcinoma. First is if the serum calcium is more than 14, you should be suspicious, it could be a cancer. Second thing is if it is palpable lump in the neck. Usually parathyroid adenomas and hyperplasias, they are not palpable. Because palpable or serum calcium more than 14, you should think about carcinoma. No, first Shreya, for starting any treatment of a condition which is not emergency, first you make the diagnosis. No, so first, no matter what drug was written there, Graves' disease is not an emergency. So you make the diagnosis and then you treat. Okay, so no matter what drug was written, the answer was still radioactive iodine uptake. So because the calcium level is more than 14, so it is parathyroid carcinoma. It is carcinoma. Okay, Anushka, I guess I answered your question. One more thing, let's see in this primary, secondary, and tertiary. One difference, one important difference. Let's talk about the comparison of PTH, calcium, and phosphate. PTH, so obviously because it is hyperparathyroidism, so it will be high in all the three types. Jaw tumor signifies that there is increase in PTH, and in jaw tumor basically the calcium is taken and that is replaced by hemosiderin. So that is just giving you a hint that there is, we are going in the in hyperparathyroidism. Calcium is high. In this case, either it is normal or low. This is very important. In secondary, it's because of hypocalcemia. Now, in response to hypocalcemia, PTH has increased, and this increased PTH will bring the calcium to either normal level or slightly towards the lower side. And phosphate will be low. In this case low, in this case it is high, because usually in renal failure the kidneys are not able to excrete phosphate. So this thing I want you to remember if you have not written this. Calcium, it can be high in primary and also in tertiary. Okay, yes, MEN1 is parathyroid, I mean adenoma or hyperplasia usually. Okay, so the answer here is carcinoma. Carcinoma. Why not A? Because tertiary hyperparathyroidism is seen when the patient is, there should be some history of after renal transplant. Okay, just remember like this. If they want to ask you about tertiary, they will give you that after renal transplant the patient is having the same thing. Okay, because it is no question given here, no answer, I mean nothing is given in this question that the patient underwent renal transplant. After the treatment of secondary, if it persists and it goes beyond suppose the secondary hyperparathyroidism because of chronic renal failure is corrected by transplant, even after that if it persists, then it is tertiary. And even in tertiary the calcium will not go 14.5. So the only reason why it is carcinoma is because calcium is 14.5, more than 14. Okay, I guess this is good enough differentiation between autonomous, like right after renal transplant. Okay, I guess now you can answer any question related to primary, secondary or tertiary. No, it is not mandatory that in cancer it will be 14, but more than 14 is mostly we suspicious of cancer, because in adenoma and hyperplasia it will go between 11 and 14. The moment it is more than 14, sometimes even for practical purposes, I'm telling you, if the gland is palpable, it is carcinoma. I have seen adenoma also palpable, but you don't have to see all the possibilities in your exam. Exam may you have to follow what is written in the book, and this is what written in the book. Next question, female, 3-month history of left-sided neck mass and 4 centimeter non-tender, moves laterally but not in the craniocaudal. I guess this will give you the diagnosis. Moves laterally but not craniocaudal. CT shows 4.5 centimeter at carotid bifurcation. This area, let me use this area. There is a mass. Follow-up angiogram is obtained. Which of the following statement is most accurate regarding this case? Now you tell me what is the diagnosis. What is the diagnosis first? Then we'll go to the questions. What is the diagnosis? Question number 10. Diagnosis. All of you. It is, yes, carotid body tumor. In exam also make this a habit. When a question comes to you, first you try to find out what is the diagnosis. Okay, don't start looking at the options. Find out the diagnosis, try to come to the diagnosis. Now you see the options. It represents the most common paraganglioma in head and neck. That is the true statement. This is correct. Okay, most common paraganglioma in head and neck is this. Rate of malignancy is 40%. It is almost, you can say 6%, less than 10% is rate of malignancy. Mostly it is a benign tumor. Majority of these shows functional secretion. No, it is non-functional. It does not secrete any catecholamine. Non-functional. Okay, majority of these are non-functional. Maybe 1%, 2% can be functional. Majority are non-functional. This tumor is very vascular tumor and also in the vicinity of very great vessels. So FNAC or biopsy should not be done. Should not be done. So the only correct answer here is option is A. 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 So you can see this is the carotid body. The most common cause of hypercalcemia in admitted patient. I am not the correct person for that. I guess medicine people, they deal about this causes of hypercalcemia and the other thing. We as a surgeon, we just know that as per our territory, or you can say the diseases we deal, we know just hypercalcemia means parathyroid, but obviously there are n number of reasons for hypercalcemia. You should ask medicine faculty about the causes and the most common cause in admitted, non-admitted patient, not related to surgery for sure. This is a site of carotid body tumor, side of the neck at the carotid bifurcation. If you try to move it horizontally, it will move, but not upside down. Okay, and this is the tumor, the splaying of the carotid vessel on angiography known as Layer sign. I am sure Sumer sir I have told you this Layer sign. Paraganglioma. See the meaning of Samreen Sheikh. See what is a pheochromocytoma? It is a tumor arising from the adrenal medulla or chromaffin cells elsewhere in the body. Now those tumors which are arising from chromaffin cells elsewhere in the body, which you call it as extra adrenal pheochromocytoma, that is actually known as paraganglioma. So all the extra adrenal pheos are known as paraganglioma, and this is one of the site. There is one at the tubercle of Zucker-Kandel near the aortic bifurcation, pelvis, neck area, mediastinum. These are the different areas where you can see the paragangliomas. So I guess the answer is correct, A. Okay, next question. 65-year-old male undergoes parotidectomy for a parotid neoplasm as shown in the figure. So they are doing a parotidectomy. Which of the following is true regarding parotidectomy? True. The facial nerve is typically found 3 cm anterior, inferior and deep to the tragal pointer. It is within 1 cm, although it is more technical. 1 cm inferior, 3 cm तो बहुत दूर हो गया. Fraze syndrome is caused by injury to greater auricular. यहीं पर this is wrong because Fraze syndrome is due to, I guess there auriculotemporal. A common complication of parotidectomy is injury to the greater auricular nerve, which causes perioral numbness. See, greater auricular nerve, if injury is there, it causes loss of sensation near the angle of mandible. Sensory loss at mandibular angle. Perioral numbness, so more of a feature of hypocalcemia. Fraze syndrome as a result of aberrant innervation of sweat gland by the postganglionic parasympathetic fiber is very much correct answer. That is, most of you are also saying the same thing. Okay, Dia, see, option number B is not because of greater auricular. See, 3 nerves which are at risk of injury during the parotid surgery. One is facial nerve. Obviously, facial nerve, all these branches, temporal, zygomatic, buccal, mandibular and cervical. Obviously, this is very important nerve which is at risk of injury. See the other nerves. Can you see auriculotemporal coming here? Greater auricular going here. And this is the area. This is facial. I am marking with green. These are the 3 nerves. And obviously, parotid is present in this area. So when you do surgery, these 3 nerves, auriculotemporal, greater auricular, and this they have not written, I'll write facial. These 3 nerves are at risk of injury. Auriculotemporal causes, injury to auriculotemporal causes Fraze syndrome. Facial nerve is very obvious, a deviation of mouth and tearing and all those things. Greater auricular is the most commonly injured nerve. Most commonly injured nerve. Okay, now let's see facial nerve pointers. Okay, the markers to identify facial nerve. This is digastric muscle, posterior belly of digastric. You can say just above the posterior belly of digastric. This is that cartilaginous pointer or the Conley's pointer or the tragal pointer. You can see 1 cm below and inferior. These 2 are very important. Okay, you can see here also posterior belly of digastric just present here, tragal pointer just below there. Okay, these 2 points. Most important they say is tympanomastoid suture line. Okay, tympanomastoid, between the tympanic bone and the mastoid, this area you can see just inferior to this. Tympanomastoid suture line. This is facial nerve. Stylomastoid foramen is another marker. Stylomastoid foramen, from where it emerges. And sometimes you make a hole in the you can say the mastoid and find it before it emerges into the face. And many times you can see these branches at the root, at the main trunk, it is quite deep, but as it goes superficially in the peripheral branches, it becomes superficial. So then in that case you can find a peripheral branch and trace it back towards the main trunk. So from periphery to main trunk is also one option, especially in the cases of recurrent cases when there is already adhesion. In this case, you can go for that. Okay, so I guess now it is very clear. Fraze syndrome is that gustatory sweating because of this reason. Okay, 68-year-old male and 2 cm lesion as pictured. So I don't know whether you can see the picture clearly or not, but there is that ulcerative lesion in the tongue. Biopsy is consistent with squamous cell cancer and depth of invasion 4.5, 2 cm, 4.5. It looks like T1 tumor. No lymph node involvement, N0, and metastatic is also 0. What is the appropriate management for this case? So this is a CA tongue patient. Carcinoma tongue, although stage 1 is this. So in stage 1 tumor and stage 2 tumors, actually stage 1 and 2 tumors, Because head and neck tumors are, photo was not given, okay, then it is mistake from our side, so I apologize for that if the photo was not given to you, but chalo, let's see. So when you do the surgery, in this case you can go for either surgery or radiation. Both are viable option, good option, but most of the time we prefer surgery unless the patient is not willing for surgery or the patient is not fit for surgery. Then radiation can be done in stage 1 as well as stage 2. But if it is stage 3 or stage 4, then in those cases you have to do surgery as well as radiation, and these days chemo is also given to most of the patient. So multimodality for higher stages, single modality for lower stages. Now see, suppose this is the tongue, this is the cancer. You take some margin, they say 10 to 20 mm margin is good enough. 10 is minimum, 20 mm is the ideal margin. So after removing this, if there is less than 1/3 of the tongue is removed, then it is known as partial glossectomy. Partial, I'll write G means glossectomy, so okay, I'll write glossectomy once. 1/3 to half of the tongue remove, hemiglossectomy. Half to 3/4, near total. More than 3/4, total. Yes, confusing TNM. TNM staging is very what to remember, what to not. List of tumors whose TNM we should learn. Let me answer this question and then I'll tell you. Okay, or let me finish and then I'll tell you. I mean, there are 2 more questions maybe. So when we talk about the reconstruction, see, in this case just primary repair, no need of reconstruction. In this case, radial forearm flap is a better type, and in these cases these days there is anterolateral thigh flap, or you can go for pectoralis major myocutaneous also, or you can go for sometimes rectus abdominis, but nowadays they are using these flap. Radial forearm flap can also be used. Anterolateral thigh is more preferred these days. Okay, like in this case you can see this was the tumor, so after removal this is the radial forearm flap and that has been put, and obviously this is not for the taste but for the so that the patient can speak. This is the anterolateral thigh flap which is based on circumflex femoral artery, and you can use a whole tongue reconstruction. Okay, and let's see, suppose tongue cancer with lymph node involvement, you go for modified radical neck dissection. This is most common, although you can go for radical neck dissection also, but mostly people they go for modified radical. Tongue cancer without lymph node involvement, you will do a type of selective neck dissection which is known as supraomohyoid neck dissection, extended version. Extended supraomohyoid means level 1 to level 4 you will remove from that particular side because it is a high risk type of tumor. Okay, so let's see what should be the answer. Partial glossectomy, no need to do radical neck dissection, lymph nodes are not involved. This looks good. A partial glossectomy with ipsilateral selective neck dissection, because the tumor is very small, so even if you take 2 cm margin it will be partial glossectomy only. Radical neck dissection, so we don't have to do. Selective neck dissection, which type? Extended supraomohyoid neck dissection. Few people they call it as anterolateral neck dissection also. Oral cavity oral cavity staging is same for the lip, tongue or buccal mucosa. Okay, the staging is same for all the 3 common oral cavity cancers. Let me finish, and I'll finish the session by telling you the important TNMs for the exam. Which of the following is false regarding the sequence of events in wound healing? False. Initial vascular response is vasoconstriction followed by vasodilatation. Whether vasoconstriction is the initial response or not, tell me. Obviously, there is initially vasoconstriction and that hemostasis, vasoconstriction, and followed by, when there is inflammatory phase, there will be vasodilatation. So this is correct. The phases of wound healing: inflammatory phase, proliferative, and remodeling. Very much correct. The proliferative phase is mainly fibroblast, myofibroblast. This is correct. The content of collagen in the wound continues to increase throughout the remodeling phase. This is wrong. Okay, see, I can see most of you are telling the correct answer. So why were you saying at the beginning that the paper was tough and you got only 8 right or 7 right or what? Looks like you got most of the questions right. I don't know. Let's see. See, in the healing response, hemostasis is the first thing, stop bleeding. Then this chemotaxis occurs, epithelial migration. Then there is proliferation, maturation, contraction. All these remodeling is what is happening in the end. In remodeling phase, type 3 collagen gets converted to type 1 collagen till the ratio is 1:4. This you all know. The remodeling can go up to 1 to 2 years. See, this is what I'm saying, that you need to see the options first. There is no need to hurry. See, what is the first cell to come? Platelet. Immediately they come. Platelet. Then comes neutrophils. Okay, platelet I'll write immediate. Neutrophils usually come in 24 to 48 hours. Then comes this macrophages, monocytes, 2 to 3 days. Then this fibroblasts, 3 to 4 days, and then myofibroblasts, lymphocytes. This will keep on coming. So this is the order in which the cells they appear in the wound healing. This is the order in which the cells they appear. Okay. See, initially neutrophils, then macrophages, then fibroblasts, lymphocytes, they come later. Okay. Initially, the type 3 collagen is more when there is granulation tissue. Later on, type 1 collagen is more. I told you in the remodeling phase, type 3 gets converted to type 1. Okay, so what is the correct answer here? I guess I marked the answer also. This is the false statement, and this is our answer. The content of the collagen does not keep on increasing, and the remodeling phase, it is converting from one type to the other type. The overall content remains same. If the collagen increases, then it forms abnormal wound healing like keloid and hypertrophic scar. Excessive collagen can cause keloid and hypertrophic scar. Okay, Shubham, I guess you know more than me, but welcome to the class. Welcome to the class. Oh no, okay. Second last question. All of the following are correct except Mondor's disease is a superficial thrombophlebitis of breast. This is correct. Mondor's disease is when there is that tender cord-like structure, superficial thrombophlebitis. So true statement. Zuska disease is a chronic draining sinus from the mammary duct. This is also correct. This is duct ectasia. Duct ectasia. Meet. I know these people, Shubham Ghai and other people, because this is YouTube session. Anybody can join. So most welcome. Let them say the things. This is good for us actually. Okay, there should be some entertainment. Okay, don't worry. Shubham is most welcome to come to Delhi and see my degrees and my college and wherever he can go. So there are people who do these things, but in this world, in this era of social media and all, you have to ignore many people. So don't worry. Still, if Shubham wants to learn anything, he is most welcome. If he asks any questions related to the surgery per se, he is most welcome. Okay, so this is also true. Zuska disease is a type of duct ectasia where there is a recurrent periductal mastitis. Duct ectasia with periductal mastitis, which is a recurrent type, and Zuska disease is mostly seen in diabetic patients, smoker patients. Okay, now Batson plexus allow breast cancer to metastasize to the vertebra. So this is true. See, Batson plexus is from the skull base to the sacral promontory. These are the prevertebral venous plexus. This is the Batson, and these plexus, they don't have valve, so it is a very potent path for the spread of like thyroid cancer, the breast cancer, the prostate cancer to the vertebra, to the brain. This is a very important path. See option number 4. Paget's disease is the primary cancer of areola. Paget's disease is not a cancer of areola. Paget's disease is a ductal cancer. Basically, it has to be a duct cancer. It cannot be seen in lobular cancer. Ductal cancer, it can be invasive ductal cancer, or it can be ductal carcinoma in situ. So these, from here the tumor cells can spread through the duct and can reach up to the nipple areola complex, causing itching, erosion, scaly lesion, and ultimately nipple areola complex can disappear. So you have to take the biopsy from this area, which looks like eczema. Many times the patient, they go to the dermatologist. Paget's disease is a cancer, okay, Shama, but it is not a cancer of areola. Okay, it has not arises from the areola. It has arises from the duct. It has arises from duct. Yes, Shubham, you are most welcome anytime. Okay, if you are in Delhi, please come. We'll have chat. We'll have tea together. Okay, most welcome. Most welcome. Okay, so this answer here is option number D. That is the wrong statement. Okay, so this is a wrong statement. Let's see the last and final question. Select the most appropriate site for initial trocar placement in a patient undergoing laparoscopic niscence with a previous midline scar from xiphoid to the pubis. Now you tell me the answer. Tell me the answer of this question. Tell me the answer of this question. See, when we do a laparoscopic surgery, what is the initial step? Initial step is we need to put carbon dioxide inside so that we can create some space in which we can go work. Mostly we make a very small incision and put a needle here, which is known as Wieris needle. Can you see this is Wieris needle? Okay, so around the umbilicus we put the Wieris needle. This is a spring loaded needle. Okay, and this is how you put around the umbilicus, either through the umbilicus or just below or just above. So when this needle goes inside, you can see the moment it pierces the peritoneum, this obturator part comes out so that the sharp part does not hit any internal organ. And then from there you will give carbon dioxide. After the abdomen is filled with carbon dioxide, you will put the first port. This is the first port. Through the first port you will put the telescope. Now telescope will show you whatever is inside, and now the other ports you can put under vision. So at two areas we are blind, where at the Wieris needle and at putting first port. Injuries can occur, they do occur, but most of the time people, they manage. Suppose the patient comes, what is the question? Previous midline scar. So if there is a midline scar, patient has come like this. So obviously if there is a scar, means there was surgery done, and there are very high chances that there is some adhesion present in this area. Some kind of adhesion present in this area. So just imagine from inside, if you see, there are chances that maybe intestine is adhered to this area, maybe omentum is adhered to this area. Okay, so if you try to put Wieris needle, or if you try to put the first port, there are obviously in these two areas you are blind. So there are chances that you do injury. So the one thing you can do in this case is go for the open technique. Open technique, which is known as Hassan's technique. So what we do in Hassan's technique, see this kind of incision we make around the umbilicus. We open the things, open the abdominal walls in layers. And slowly we open the skin, the subcutaneous tissue, anterior rectus sheath, posterior rectus sheath. And then when we open the peritoneum, you put your finger inside and try to sweep if there is anything there adhered. And then you put the port directly. Can you see? there is no Viris, directly the port is there. So that is Hassan's technique. But suppose somebody says, no, I don't want to go with open technique. Just tell me if there is any other site from where I can put the Viris needle. Then that site is this area. Can you see this area? Left upper quadrant, just 1 finger breadth below the costal margin in the mid clavicular line. This is Palmer's point. This is Palmer's point, and this is the safe area where you can put the Viris and where you can put the first port. So Viris and first port you can put at this area, and after the first port, when you put the telescope inside, now everything is under vision. Okay, so the patients who you are operating for the incisional hernia or the prior abdominal scar, either you go for the open technique or go for the Palmer's point, that is left upper quadrant. Left upper quadrant. Okay, so fine. So these were the 15 questions. Okay, I was supposed to finish that in 1 hour, but chalo, 15 minutes more I have taken. But now you can see the questions were not actually, I will not say that it was very easy, but it was not very difficult, and none of the questions were out of context. Everything is important. All these topics are important. All these topics they have asked question in the past. Okay, left lower quadrant is this area. Okay, this is not that safe area. If you put the Viris or you put something else, you might cause injury to the iliac vessels is there, sigmoid colon is there, small intestine is there, so it can cause injury. It can cause injury. Okay, so thank you very much. You are asking the important TNM, so that I'll tell you. TNM in, like, let's say like this, general surgery part. Breast cancer, oral cavity cancer, just 2, not more than 2, just 2. Little bit about thyroid, if you want to see, you can see, otherwise that is fine. Urology, GIT, hepatobiliary pancreatic. Let's see, hepatobiliary pancreatic, just need to remember the gallbladder cancer, and that too I would not say that you remember the whole thing. Just remember, if it is T1A, only mucosa, then the surgery is a simple cholecystectomy. T1B to any other, radical or extended. Okay, so they don't ask as such on the TNM staging, just they ask about the question. If the tumor is limited to mucosa, simple cholecystectomy is good enough. And if it is beyond, then radical or extended cholecystectomy, in which we have to remove a part of the liver and the lymph nodes from that area. Okay. GIT, colon, colorectal is the same thing. Colon or the rectal is the almost same. It is one stage in colorectal cancer. Just one you remember from the staging point of view. Otherwise, in esophagus, in stomach, in small intestine, it is not important. Just one I am asking, colorectal. Urology, important ones. Prostate, just remember the T staging, and mainly for the treatment point of view, T staging, not the whole TNM. Kidney, here also just T staging. These are the two main. Urinary bladder, they will not ask you staging. Just remember, in this case, non-invasive tumor means if it has not gone beyond the bladder, TURBT, and if it is invasive, then radical cystectomy. And lastly, testis. This you need to know whole staging, TNM as well as the stage. What is stage 1, 2, 3 and 4. So one proper staging which you need to remember in uro is testis, the whole staging. Otherwise, prostate may just T, kidney may just T, urinary bladder may TNM is not important that much. Okay, so that is Gleason is basically a pathology topic. Just remember that Gleason score and grade is for prostate cancer. They will not ask you the details that what kind of gland you see in. That is a MCH level question. Okay, so thank you very much, and it was a good discussion, and Shubham kept us entertaining, and best of luck to all of you, to Shubham also. Even if you are PG, still lots of things to be done in PG. You need to learn surgeries and other things. Okay, so all the very best to all of you, and I'm sure all of you will do great in the exam. Read the question carefully. I can see that you are this messages were saying that you did one silly mistake, you forgot that there is all except or true or false. So these kind of mistakes should not be done in the exam. Exam is very much straightforward and easy, and I'm sure all of you will do great in the exam. Read the question carefully. Surgery, mostly they ask easy in the exam. Okay, PTFE or GSV is best for, you are asking by femoropopliteal, then it is femoropopliteal bypass, GSV is best. Okay, you will, Avinash, when you give this MCQ, when you give this TNDs and test series and all, usually the questions are above average, and in that, if you are getting low score, don't worry, just revise the surgery, revise the DVT, do the PYQs, and your score will improve. Okay. Okay, so thank you very much, and best of luck to all of you.